Okay, so now we're going to talk about blood donation and processing questions in an effort to try to minimize all these factoids and pieces of trivia you have to know about blood donation and QC and such. I kind of collated all of the high yield questions that I think are the most important to learn. So number one, what is typically the minimum weight needed to be an allogeneic whole blood donor? It's usually about 110 pounds. What is typically the minimum hemoglobin needed to be an allogeneic whole blood donor? That is 13 for males. That was recently increased in the past several years. And it remains 12.5 for females. So 12.5 for females, 13 for males. What is usually the minimum interval between allogeneic whole blood donations? That's usually 8 weeks, 56 days or 8 weeks. What is the deferral for a blood donor who took an unlicensed or research vaccine? That's a common question for donors because many donors are college students and they'll take research vaccines. So that's 1 year, so 12 months from the time you take it. 12 months. Then number 5, what is the deferral for a blood donor who had clinical hepatitis B or hepatitis C? So that is permanent deferral. They're not allowed to donate anymore. What is the deferral for a blood donor who had babesiosis? That's also permanent deferral. So it's a little bit different when you compare babesiosis to malaria. Babesiosis is permanent. Malaria we'll get to, that has some nuance to it. It's not permanent. What is the deferral for a blood donor who had a needle stick at work? So the way I think about this and this category of deferrals is that if you've had a high-risk exposure, not necessarily you actually had the illness, but if you've had a high-risk exposure for hepatitis or HIV or something like that, then it's a 1 year deferral. So a 1 year deferral after the high-risk exposure. So in this case, for a needle stick, it's 1 year. What is the deferral for a donor who had syphilis? So whether you've actually had it or you just test positive, because the test is terrible and sometimes people test positive for syphilis but they don't actually have it. Regardless, it's a 1 year deferral after testing, and if you've actually had it, it's a 1 year deferral after the resolution of it. Okay, number 9, what is the deferral for a blood donor who had malaria? There's a little bit of nuance to this, but it's not that annoying. If you've had malaria, it's a 3 year deferral. If you've had symptoms of malaria, so if they were unsure if you had malaria, it's still a 3 year deferral. And if you've lived 5 years or longer in an endemic area, then that's also a 3 year deferral, okay? So had it, symptoms of it, lived for 5 years in an endemic area, 3 year deferral, right? Versus if you've been exposed by traveling in an endemic area, but you haven't lived there 5 years, so less than 5 years, then you are deferred for 12 months for 1 year. So 3 years if you've had it or lived there for 5 years, and then a 1 year deferral if you've been exposed, but not as long as living there for 5 years. And then how much blood is removed in a whole blood donor collection? Usually in the neighborhood of 500 mLs, 500 mLs. And then moving right along, what is usually the maximum number of times per year a donor may donate apheresis platelets? That is usually 24, right? 24 times per year. What is the deferral for an apheresis platelet donor who took aspirin? Usually something like 2 days. That's a common deferral, 2 days for aspirin. What is the minimum platelet count for a single apheresis platelet donation? That would be 150, so 150 for donating platelets. What is source plasma? All that means is it's the plasma that doesn't become a plasma product in the blood bank, but it becomes other products that end up in the pharmacy. Things like it becomes albumin, IVIG, coag factor concentrates, things like that. Source plasma. And you could pay people to donate source plasma, but you can't typically pay donors for blood products that will end up in the blood bank. And what is an infrequent plasma donor? Well, infrequent means you don't donate as frequently as every 4 weeks, whereas a frequent plasma donor means that you donate every 4 weeks or more frequently. And How do eligibility requirements for infrequent plasma donors different from whole blood donors? Well, they don't really differ. The main thing I'm trying to get at is if you're a frequent plasma donor, you have to test for things like their total protein, their total immunoglobulins, and do an SPEP to make sure that you're not making them, protein or immunodeficient. And also you could donate plasma for source plasma every 2 days and up to twice per week. Every 2 days and up to twice per week. Then, moving right along, what are 3 examples of allowing a donor to donate at a shorter time interval due to exceptional medical need? And so what's one example for red cells, platelets, and plasma? Well, for red cells, if they have a rare phenotype and you have a patient that can't otherwise find any blood from, say, relatives or frozen units. For platelets, it could be a similar story, like, for example, a neonate has neonatal alloimmune thrombocytopenia, and the only source of the rare phenotype is the mother, and she could donate more frequently, right? That's an exceptional medical need. And finally, plasma, and it's not so much a phenotype in the sense of having antigens and such, but you could find IgA deficient donors, right? Because donors who are completely deficient in IgA, they could donate more frequently. What is directed donation? As it sounds, that's when you're trying to donate for one particular patient, right? It's not like an anonymous pool of donors that can go to any patient that needs it, but it's like a parent donating for a kid or vice versa, or sibling to sibling, that kind of thing. And then, can unused blood products from a directed donor be routinely released into the general inventory? Yes. So if you're an allogeneic donor, then you have certain requirements, and if you've met those, and the person that you thought needed the blood product turned out not to need it, that blood product can be used for other patients. Which has a higher prevalence of viral marker positivity, directed donors or the overall donor pool? What are the 2 reasons for this? It turns out that directed donors, broadly speaking, have a higher viral positivity prevalence compared to the overall donor pool. And one reason for this is there tend to be more first-time donors among the group of directed donors, right? If you could imagine, we have a sick relative, let's gather all the relatives, all the friends together to go donate for little Jimmy. It's likely that the percentage of first-time donors in that group is going to be higher than the overall donor population, right? Which tends to be a lot of repeat donors. And one distant second reason for this is also if somebody tells you, hey, we're all going down to donate for little Jimmy, and you have something that you don't want to disclose, right? If you have something you don't want to disclose on the donor questionnaire, then you may not say that because you don't want to walk away from the donor center and not donate, and then have everyone ask you, hey, how come you're not donating? You don't want to have that conversation. So some people are more prone to just not disclose everything, and it turns out something is positive when they do the infectious disease testing. So, can unused blood products from an autologous donor be routinely released into the general inventory? So autologous means donating to yourself, and no, because they have lower standards for donating, give lower standards for donating autologously to yourself, we don't generally move that into the general inventory. No. Describe the process of autologous donation. The criteria are lower, the standards are lower. The minimum hemoglobin is only 11 instead of 12.5 or 13. It's okay, actually, if you have viral marker positivity. So many blood banks get nervous about having autologous units with viral marker positivity in their blood bank, because what if there's an oopsie and if a tech accidentally picks this donor unit when they meant to pick another one, and you know what I'm saying? A virus positive unit goes into a patient accidentally, that could be bad. So we get a little bit squeamish about that. For that reason, we usually require the physician of the patient to give us an order to do the autologous donation. This has become a lot less popular in the last, say, 10 or 20 years, but it was really popular in the 80s for obvious reasons. What is typically the minimum hemoglobin level needed to be an autologous blood donor? We already mentioned that, 11 grams per deciliter. Moving right along, what changes in blood pressure and pulse are seen in a basal-vagal reaction? So a basal-vagal reaction, if you didn't already learn this in med school, is when both the blood pressure and the heart rate go down. That's the classic responses, as opposed to hypovolemia, right? If you're volume depleted, classically you'll see a decrease in blood pressure, but a compensatory increase in your pulse, whereas vasovagal is a decrease in both blood pressure and pulse. What other signs and symptoms may occur in a vasovagal reaction? The patient might pass out, the patient might vomit, the patient might feel cold. Those are kind of the main things. Feel faint. How should a vasovagal reaction be managed? Try to lie them down, elevate their feet, right? Sometimes cold compresses to the face, to the neck help. If they're hyperventilating, which I didn't mention, that could be another possible sign or symptom, that if they're hyperventilating, have them rebreathe into a paper bag. And then if they pass out and you can't revive them, right, and you've tried everything initially and done the ABCs, and sometimes ammonia smelling salts might be used. I wouldn't use that like as the first thing, obviously, because then you just annoy people with the smell. And then of course, if somebody passes out in your donor center, ask for medical help immediately. Call a code if it's relevant. Ask the relevant people for help immediately. Chapter 9, what are the heat labile coagulation factors? So we're moving from blood donor eligibility and blood donor adverse reactions to kind of QC and blood product processing. So what are the heat labile coagulation factors, meaning which coag factors decrease the most in warmer temperatures? These are factor 5 and factor 8, right? Factor 5 and factor 8. Coincidentally, also the ones that are inactivated by activated protein C with its cofactor protein S. Bonus coag, you're welcome. Additive solutions such as Adzol allow a maximum red cell shelf life of how many days? That would be 42 days or 6 weeks. So you can store red cells at most 6 weeks, and you could, as we saw before, you could donate at most every 8 weeks. So you can't keep up with your own blood inventory because you could store at 6, but you can only donate every 8. Red cells stored in additive solutions have a hematocrit of approximately, it varies, but somewhere in the 55 to 65 range is a typical hematocrit. Plasma is stored at what temperature? In the freezer, right? So approximately 0 to say -10, and has a shelf life of up to 1 year, Plasma is thawed at what temperature? 37 degrees. Thawed plasma is then stored at what temperature? You store thawed plasma typically in the refrigerator, right? And that has a shelf life of up to 5 days after frozen plasma has been thawed. What is the main indication for cryoprecipitate? If it were up to me, I would just rename cryoprecipitate fibrinogen, because the main indication is, guess what? Fibrinogen replacement. How is cryoprecipitate made? That's when you take frozen plasma and you put it in the refrigerator and then let it gradually, the fibrinogen and some other stuff will gradually precipitate out. Then you centrifuge it, and the supernatant is so-called cryoprecipitate poor or cryoprecipitate reduced plasma, whereas the pellet is the cryoprecipitate or the fibrinogen, right? What is the minimum amount of fibrinogen and factor 8 per unit of cryoprecipitate? The minimum amount of fibrinogen is 150 milligrams per unit, 150 milligrams per unit. The average is typically 250. The average is typically 250. And factor 8 as a minimum per unit of cryo is about 80 international units. It's kind of an absurd QC requirement because ain't nobody giving cryo for hemophilia A, right, or von Willebrand disease. They have drugs from the pharmacy for that. But we're stuck with that for now. Cryoprecipitate is stored at what temperature, in the freezer. And it has a shelf life of up to 1 year. So it has the identical frozen storage requirements as plasma, in the freezer for up to a year. What is the minimum number of platelets in apheresis platelets? Of the ones that you test, 90% of them have to have 3 times 10 to the 11th. 3 times 10 to the 11th is the minimum for an apheresis dose. Platelets are stored at what temperature? Room temperature, 20 to 24 Celsius, 20 to 24. They have a shelf life of up to 5 days, 5 days. That's why we can't stockpile them, because it's only a 5-day shelf life. What is the main indication for granulocytes? There's lots to say about granulocyte transfusions, but it's mainly an absolute neutropenia, usually less than 500. A documented, either via culture or radiology, a documented bacterial or fungal infection that is refractory to the best available antibiotics. And those are 2 definite requirements, and a third one that's kind of unstated, which is that there's some sort of reasonable expectation that the patient will start making their own neutrophils again, start making their own functional neutrophils again. So it's usually something like a bone marrow transplant patient, and they have yet to engraft, and they have a documented infection that persists. What's the shelf life of granulocytes? That's 24 hours, but it almost never sits on the shelf that long. Usually it goes right from the donor as quickly as possible to the patient. Should granulocytes be irradiated? Yes, they should be irradiated, mainly because there are still, of course, it's mainly neutrophils, but there are still some T cells from the donor in the bag, and usually we're dealing with a severely immunosuppressed patient, so we want to irradiate so that the T cells don't proliferate when they recognize the patient as foreign and cause transfusion-associated graft versus host disease. And just to give you some blood bank humor that is part of our little world, granulocytes should be irradiated. They should not be leukoreduced. They should not be leukoreduced. Sorry, I know that's awful, but everyone makes that joke. Finally, chapter 10, what is the most likely explanation for a donor who is O positive on her donor sample, but consistently tests as O negative as part of her prenatal care several years ago? So several years ago, she was clearly O negative. And now when she comes to the donor center, she was told, hey, I was O negative. They told me I have the universal donor type and I should go donate red cells. And she shows up and then she discovers she's O positive. And then she yells at you for messing up her ABO type. What's the most likely explanation there? Yes, that is usually due to weak D, right? Weak D is kind of like as we talked about before in the previous videos, like a gray area between positive, D positive and D negative. And we test donors for weak D, but we don't test patients for weak D. So that's why she ended up being labeled O positive, even though she's weak D, as a donor, and she was labeled as O negative as a patient, because patients are not routinely tested for weak D unless it's a neonate of a D negative mother. Are donors tested for unexpected red cell antibodies? Do donors get antibody screens? Because sometimes people ask, well, can a plasma donor have an anti-D and anti-big K, whatever? And the answer is yes. Donors are tested for unexpected red cell antibodies. They do get antibody screens. What is extended phenotype matching? There's lots to say about this when we talk about sickle cell patients, but very briefly, we look at, instead of just the ABO and the D, we look at more antigens. We try to match for more antigens between the donor and the recipient. And it's common to look at things like the Rh system, KEL, Duffy, KID, and then big and little S, to try to prevent antibody formation in a sickle cell patient, not because antibodies by themselves are worth stopping, and not even because delayed hemolytic transfusion reactions are worth stopping, but we're primarily trying to stop or prevent the rare complication of a delayed hemolytic transfusion reaction, which is hyperhemolysis syndrome, which for unclear reasons, can start out as a delayed hemolytic transfusion reaction in a lot of, I shouldn't say a lot, in some sickle cell patients. And for unclear reasons, kind of turns into also an autoimmune process, or broadly speaking, a process of destroying the patient's own red cells, not just the transfused red cells. So that's primarily what we're trying to prevent when we do extended phenotype matching. Which patient populations typically receive phenotype matched? Really any patient who's chronically transfused, which is in our world usually sickle cell patients, thalassemia major, one of these congenital dyserythropoietic anemias, type 2s, you know, things like that. Things that will require kind of lifelong transfusions. And what is the goal of providing extended phenotype matched platelets? Proximally is to prevent antibody formation, but really it's one or two steps removed from that. It's to prevent delayed hemolytic transfusion reactions, and not them as such, but to prevent the rare complication of hyperhemolysis syndrome. Okay, that's all I have about blood donation and processing. I'm not going to tell you to do the quiz questions because you just did, so you have learned something.